from me?
Closing speech, I mean.
Closing speech.
Yeah.
Okay. Based on our study, I have actually presented for a three phases study that we conducted, whereby we actually come up with our own this module development, and we actually also conclude that from our module is actually reliable and valid, and for the factors associated with the children among 2 years less than 2 years old in Terengganu, we also come out and also found that the factors associated are basically the low birth weight, also mother's knowledge level, and also the height of the children plays an important role. So when we move to the phase 3 study, we also found that in fact this nutrition intervention module is actually effective, especially when we're looking at the mother's knowledge. There are improvement in terms of the mother's knowledge when we conduct among the case as compared to the control. So which means that mothers who are equipped with the good nutritional knowledge is actually good to help them, okay, to design a good nutritious meal for their infant, especially after they were born until 2 years old, so that during this window period, they will get enough good nutritious food to prevent stunting. Okay, so basically, we would like to recommend perhaps when mothers go to the clinics for their health checkup, they need to be explored on the nutrition module, okay, for their this knowledge to prevent the stunting from happening in their newborn. Okay, and I would like to also thank the first International Conference Center of Excellence, Poltekkes, Kemenkes, Kendari, for inviting me to this conference and to share our these research findings. Feel free to contact me if you need any further information.
Okay, thank you, Dr. Bion, and we hope we can see you not only online but also offline in Malaysia or Indonesia or in another country. Don't know. Okay, thank you so much for today, and yeah, big thanks for Professor VP and big applause for you. Thank you.
Thank you, Professor.
Thank you.
See you again.
Thank you, Prof.
Okay, Alhamdulillah, the session of Dr. Bibi has been finished. So now we will continue in the next session for the first panel, first presentation session in day 1 with our speaker, Dr. Charito Embernido, RMT, MSMT, PhD. Are you here, Dr. Charito?
Yes, I am. I am in.
Okay. Are you ready now for presenting your material?
Yes, I'm ready. Thank you.
Okay. Okay. Thank you.
Thank you
Dr.
very
Charito.
much. Okay, before I present, let me thank the organizers for this excellent international conference. Really, this is a trailblazer because you are the first international conference to be organized in there. So congratulations to the organizers, and we hope really we can do more collaborations in the future. So let me share my screen now.
Okay, sorry, Dr. Charito, but before that, we want to introduce yourself briefly. It's okay?
It's okay.
Okay.
All right. I'm Dr. Charito Bermido, and I'm the Dean of the School of Medical Technology or Medical Lab Science of Central Escolar University. Our university, our program, MedTech, is the first one to have the highest level of accreditation in the Philippines. We are also a supplier of most medical technologists, and the government, through the Department of Science and Technology, had recognized us because they send scholars to our school. So anyway, we have 3 campuses, Manila, Malolos, Makati. So we've got lots of students, and really, I'm happy to represent Centro Escolar University. Thank you very much.
Okay, thank you, Dr. Charito. You have 1 hour and 30 minutes, 1 hour for presenting your material, and then continue with Q&A session, please.
Okay, thank you very much. May I share my screen?
Yes.
So my topic will be on hematologic malignancies or malignancies involving the blood and the peripheral organs. Let me have first the historical perspective of malignancies.
Sorry,
Actually,
Dr. Charito,
yes.
the slide can be present fully?
Excuse me, I'll just ask my assistant.
Okay, thank you.
Oh, is this okay already? Hello?
Yes,
Is the
already full.
slide fully visible?
Yes,
Thank you.
full. Yeah.
Actually, malignancies of the blood result from abnormal growth of cells of the hematopoietic system. When we say hematopoietic system, this will involve all blood-forming organs. This is not hereditary, and it is the first human cancer in which a consistent genetic defect was identified. Okay. Virchow was first to report leukemia between the 1839 and 1845. In 1960, Noel and Hungerford described the Philadelphia chromosome or the shortened chromosome. Now was confirmed to be a reciprocal translocation of chromosomes 9 and 22. Okay. In 1982, Taub and colleagues reported the translocation in Burkitt lymphoma. Okay. So let us compare a slide on the normal blood cells and a slide with the leukemic blood. As you can see, most leukemia, with the exception of few, is really a proliferation of the white blood cells. You can see the leukemic cells, the young cells there, growing, proliferating uncontrollably. We have here normal blood. Of course, we know that the blood, the most abundant of all the cells, are the erythrocytes or the red blood cells. In leukemic blood, we can see that the WBC or the leukocytes overtake the erythrocytes or the red blood cells. So we can now see that there is profuse formation, uncontrollable, no apoptosis. So this is something not healthy. Okay. Acquired genetic diseases, okay, and most patients are not born with this condition, not hereditary. This is acquired sometime later. Okay. So we will talk about leukemia, anemia, meaning blood, leukocytes abound in the blood. We talk about lymphomas when the cancer is confined to the lymph nodes. We talk about myelodysplastic syndrome, previously called the preleukemias. Okay. Most hematologic malignancies are not localized, but are systemic. When we say systemic, then they proliferate and they involve multiple organs. From the blood, they go to the lymphoid, tissues, and other related organs. Even the liver, even other organs, even the brain in some leukemias. Really systemic. So this is really a term, a treatment that will really entail and affect most organs. So we do not have localized treatment. Now we move on to the etiologic factors. By etiologic factors, we mean the causes. But actually, these are just theories or proposals because we cannot really pinpoint for sure. This will entail a lot of research for us to be able to say for sure that really there is this cause. Let's move on to the first identified and suspected cause, environmental toxins. Environmental toxins like radiation exposure, exposure to ionizing radiation, any radiation, like X-rays and other radiation. Okay, there are plenty now of identified ionizing radiation. Even exposure to organic solvents like benzene, chloroform, and all that. After treatment with alkylating agents and other types of chemotherapy, okay, this therapy damages the DNA. It damages the DNA, leading to hematologic neoplasm. So neoplasm, cancer. Okay. Immunosuppression, a phenomenon which the immune system of the person is suppressed. And so the leukocytes or the white blood cells cannot anymore reject pathogens. And this is something that is very alarming. Just like in the treatment for HIV, people with HIV, when they are immunosuppressed, then they can later on have non-Hodgkin's lymphoma. Okay. The molecular pathogenesis is also being described and studied more deeply. In hematologic neoplasms, mutations or deletions disrupt key genes coding for various cellular proteins and processes and may result in one or more of the following. Uncontrolled proliferation caused by mutations in genes coding for signal transduction proteins or growth factor receptors that could lead to activation without stimulus and without the ability to suppress the response. Second, could be loss of DNA repair capability and cell cycle control as a result of inactivating mutation or deletion of genes coding for DNA repair proteins, cell cycle proteins that regulate the cell cycle, or checkpoint control proteins that arrest the cell cycle. When DNA is damaged, Inactivation or loss of one or more of these proteins allows cells with damaged DNA to progress through the cell cycle and proliferate. So uncontrolled proliferation. They have established that. Another is lacking in the differentiation due to mutation in the genes coding for nuclear transcription factors or aberrant changes in their epigenetic regulation, leading to maturation arrest or dysplastic changes. Continued cell survival and inhibition of apoptosis or programmed cell death as a result of mutation or deletion of genes coding for pro-apoptotic and other related proteins. This leads to persistence of leukemic stem cells that retain self-renewal properties. So, in this condition, in this instance, there is really no apoptosis, so that there is really a large number of cells being produced. They crowd the bone marrow. They crowd plenty of them. Okay. So let us now go to the terminology. What do we mean by epigenetic mechanism? Okay, this mechanism means controlling how genes are expressed and silenced, and how they could be through DNA methylation, histone acetylation, and microRNAs. These are important for normal gene expression in all types of cells and are critical for complex processes such as embryogenesis and cell differentiation. So, really, there ought to be cell differentiation. When there is no cell differentiation, that is malignancy or cancer. Okay. So we can now here a proto-oncogene right here. They become oncogene when they are activated. So the proto-oncogene, when they are not activated that much, normal cell division happens. What happens when the proto-oncogene becomes an oncogene? Look at the number of cells that are uncontrolled, and so malignancy is evident. All right, we know that oncogenes is a proto-oncogene that had converted, no? These have leukemogenic potential, plenty of cells, leukemia. Important in the signaling pathways, ito, oncogene, cell proliferation, and even cell differentiation. Let me emphasize that the blood cells in our blood-forming organs should have the different normal stages of development. In the presence of malignancy, because of very fast formation, no apoptosis, the cells look like the same. No maturation, no much differentiation. And so, they are plentiful, and then the age or maturity, same. That is malignancy, no? They will crowd the blood-forming organs. Let's move on to the other terminology, tumor suppressor genes. They code for proteins that protect cells from malignant transformation. So these are genes that could prevent cancer or leukemia or any malignancy. How do they do it? They normally slow down cell division, the mitotic division, and they promote apoptosis. What is it? When there is no need, there are some cells that are extra or overflowing. They are not needed. They are killed through the process of apoptosis. What are DNA repair genes? Okay. Focus on the mutation in these genes that are factors in hematologic neoplasm. Mutations cause genetic instability and increase mutation rates. So there is changes. They mutate, no? They are not the normal cells, leading to increased malignant transformation, like in the case of the Fanconi anemia gene. What is this Fanconi anemia gene? It is congenital aplastic anemia. All right, let's focus on the basic types of malignancies. The very popular one, leukemia, a clonal defect, acquired clonal defect. So the clone of cells are defective, usually leukocytes, and they are found in our bone marrow. Uncontrolled proliferation happens. So the cells are not differentiated and they crowd very much. How about lymphoma? By the name itself, OMA, no? Solid tumors of the lymphoid cells. Example, the lymph node and other lymphoid organs are affected. Now we go to myeloma. We know very well that plasma cells are normally found in our bone marrow, but not in the blood. They have a certain normal number. And if the number do increase more than the normal, we call it multiple myeloma. Here is a comparison of the healthy bone marrow where the maximum number should be 1.5% plasma cells. In the case of multiple myeloma, we can see plenty of plasma cells. And this will then result in hyper-gamma globulinemia, very high amount of gamma globulin. We can see here lymphomas, no? Because they are in the lymphoid tissues. Based on our anatomy and physiology, we have 300 to 600 lymph nodes all over the body. But the most prominent are in the cervical part, axillary part, the armpit, and then the inguinal part. So in lymphoma, there is really uncontrolled proliferation. The lymphocytes are plentiful, so the lymph node is swollen, and we call that condition lymphadenopathy. Okay, so lymphoma, solid tumors, leukemia involving the blood, no? Myeloma involving the plasma cells. Okay. Is then the laboratory profile in leukemia. All right, first and foremost, anemia. This is present in more than 90% of leukemic patients. Also, leukocytosis. About 50% of leukemic patients have elevated leukocyte count or WBC count, white blood cells, but of course lower than 100,000. Thrombocytopenia, again, diminished number of thrombocytes or platelets. Basophilia is a feature of most leukemia. Basophils are very little, 1% only in our bloodstream. In leukemia, they become very plentiful. So we call it basophilia. Immature precursor cells or blast cells. When we say blast, young cells in the peripheral blood. As we know very well, the blast cells or the young are supposedly found in the bone marrow only. When they become mature, they now spill over to the blood. Kaya we call it leukocyte, emia blood. Okay. Nucleated RBCs, like in this one. When we say nucleated, they are young red cells. Supposedly, they are in our bone marrow, but then because of uncontrolled mechanism, they are now found in the blood. It's abnormal. Of course, another one is decrease in the leukocyte neutrophil alkaline phosphatase, a cytochemical stain. A non-hematologic clues can give us also this picture. When serum uric acid elevates and you do not have any gout or arthritis, then that might be a sign that you are having a leukemic process, no? Leukemic, when we have. Also a high level of lactate dehydrogenase, an enzyme from the liver, as well as vitamin B12 levels or B12 binding capacity. This is so because of the increased amounts of transcobalamin because of the numerous neutrophils found. Okay. Let's go to the classification of leukemia. Chronology, time involved. We all have heard of acute condition, acute leukemia. When there is acute leukemia, the lifespan or the life expectancy is usually 3 months. When we say, okay, a recent pronouncements from the World Health Organization based on the book by Rodak, it says that any leukemia where at least 20% of bone marrow cells are blessed. So 20%, 21%, up no 25%, we call them acute leukemia. Acute. So the life expectancy will be shortened, more or less 3 months. How about the second one? Subacute leukemia. Longer survival time, 3 to 12 months. But the clinical picture is similar to acute leukemia. How about chronic leukemia? Survival longer than 1 year if no remission occurs. As you know, remission is a condition in cancer patients where there is no signs and symptoms exhibited by the patient. So in chronic leukemia, we have less than 20% of the bone cells as blasts. When we have more, 20% or more, then we have acute condition, acute leukemia. So this is based on the chronology, the time involved. Okay. We move on to the cytologic type. When we say cytologic type, we mean the cell involved. When the granulocytes or the myelocytes are involved, we call them as granulo or myeloid. They could either be acute or chronic. So when we say acute again, I say 3 months or less. Chronic, in 1 year is the survival rate time. Okay? But this involved the neutrophils. Now we go to the next, promyelocytic. Promyelocytes abound in the blood. The next is a combination of myelocytes and monocytes. Okay, because actually when we recall our development of the cells, the myelocytes and the monocytes are cousins. They are related. They are very much related. Let's move on to the next. We have another erythroleukemia. As the name says, erythro, red blood cells. Leukemia, white blood cells. So this involves 2 cell lineages, erythroid and granulo or myelo. So we call it also Guglielmo syndrome. We have another eosinophilic leukemia, very rare, no? Eosinophilic cells abound. Now we go to the second type of leukemia, main type, lymphocytic or lymphoid. We have again acute lymphoid, okay, 3 months, survival time, chronic, longer survival time, but this time, this involves the lymphoblasts, the lymphoid cells. Now we have the next, monocytic, involving the monocytes. Okay, acute monocytes, monocytes abound, and when we say 20% or more monoblasts, we call it acute monocytic, no? So the monocytes are, we can say, 3 months survival time. Okay, acute monocytic Schilling type. This is pure monocyte. We have not, this is not pure Naegeli type. This is a mixture of granulo and mono. Now we go to the erythroblastic involving red cell. Please notice that leukemias can also happen in the red blood cell. Like in the case of Guglielmo syndrome, a while ago I said, erythroleukemia. Another one is pure red cell, pure red cell. This is pure, this is with granulo. They are classified in here. Now we have stem cell leukemia or hemoblastic leukemia. So this is very hard to diagnose because we know that stem cells look like our medium-sized lymphocytes. Plasma cell leukemia, a more serious type of multiple myeloma. The plasma cells spill over to the blood. How about the mast cell leukemia? All right, predominance of mast cells in the blood. All right, histiocytic leukemia here, reticuloendothelial cell leukemia. The next is involving the megakaryocyte or the mother cell of platelets or thrombocytes. We have megakardioblastic, younger forms are there. We have basophilic leukemia, very rare, the rarest form. We have lymphosarcoma cell leukemia. We have that. Okay. So how about classification? The first classification is chronology. We tackled a while ago. The next is the type of cell. The third one, we are now here on the release mechanism. The first is in leukemic leukemia, frank or true leukemia. Why do I say true? Because it is really full-blown. You can see in the bone marrow, same picture in the bone marrow and in the blood. So all the blood cells in the bone marrow could be seen in the blood as well. So leukemic leukemia. How about subleukemic leukemia? Immature cells in the blood? Yes, but less than 15% in here, but in the leukemic leukemia, more than. How about leukemic leukemia? No leukemia in the blood. But when you do bone marrow examination, you can see them because we can do differential count of the leukemic cells in the bone marrow. All right, we have to talk about an important condition that might bring confusion to clinicians as well as patients. When we say leukemia, it is really malignancy, cancer, neoplasm. We have a condition called leukemoid reaction. Leukemoid, a pseudo-analytical, but not true, not leukemia. A reactive condition that is sharing the same characteristic with leukemia. Very high leukocytes, plenty of immature cells like in leukemia. This could be triggered by too much or high sepsis, Trichinella spiralis infection, hemolytic anemia, as well as these conditions, overwhelming infection. In effect, we can see here, class, in a leukemoid reaction, we can see the markers for infection, which are dull bodies and toxic granulations, and they will now be removed from the blood once these infections get well. But in leukemia, we do not see dull bodies, we do not see toxic granules. because it's really a true malignancy. But leukemia and leukemioid reaction share the same blood picture, these two. So we get confused. So we have to do a differential test. No. Bone marrow examination, where in leukemia, you can see plenty of abnormal or immature cells. In the leukemioid reaction, normal bone marrow. How about the lymph node biopsy? Again, in leukemia, abnormal presence of immature cells. In the leukemioid reaction, normal biopsy result. Then, how can we now differentiate through the leukocyte alkaline phos? This is a type of cytochemistry. When we stain the young cells, we will now score in leukemia low leukocyte alkaline phosphatase score, while in leukemioid reaction high. So these are tests which could help us differentiate these two conditions because we get confused. So that's why we have to differentiate. All right. So there are two types of leukemia. Across countries, across races, 50% are of myeloid or coming from the myeloid stem cell or those coming from the lymphoid stem cell. There is acute, we have 3-month survival time, here longer, but of course involving the cells of the myeloid. In here, again, acute and chronic, but involving the cells of the lymphoid system, lymphoid. Okay. All right. So let's talk about symptoms. Acute leukemia, as we have said, of short duration, many immature cell stages. We have said 20% or more are blasts. Elevated total leukocyte count. What are the symptoms of chronic leukemia? The total opposite of this acute, no? Long duration, 12 months, or even longer, if properly treated. Mostly mature stages. Okay, some will be elevated, some will be normal. The count, the leukocyte count. Okay. So we have reiterated, this is a very important thing. But you will know later on that this is now being scrapped because who is more strict? I will explain why are they strict. So presence of immature leukocytes in the blood here, 20% or more are, no, the least is 20. 20 more acute. All right, no bleeding, replacement of bone marrow elements by tumors of young cells, usually elevated, but there is also bleeding because of low thrombocytes, low platelet count. All right, let us have here a picture of this slide shows the hallmark cell. Hallmark, these are our rods. These are primary granules that are present in acute myeloid leukemia. Look at the incidence. 5 for every 100,000 can have AML or ANLL, acute non-lymphocytic leukemia, myeloid. There are two peak incidences, 15 to 20 years, and the next peak or the next most number of patients is after 50 years. This is the most prevalent, no? Because of all the acute leukemia, this is superior than acute lymphocytic. This is congenitally found, no, in the newborn, no, many got affected. Individual with Down syndrome or Mongolism, no, has 30 times at greater risk of AML than the general population. I repeat, this is our rods. our rods. And we call this cell fagot cell. When a pathologist can see the hour rods, then he will be suspecting that there is AML. So, 70% of patients die of infection, of soldiers in the body, plenty of WBC, neutrophils, but they are not normal. They don't function well. So patients don't have protection, no immunity. So they die of infection, most of them. Again, survival time, 3 weeks. Ayan, okay. Modern treatment. All right, let me emphasize this. Remission rates are inversely related to age. The younger the patient is, the more is the remission. Or the signs and symptoms will not be felt. All right. The older the patient is, right, the less is the remission, inverse proportion. Modern treatment are also effective in younger patients than aging population. Molecular, of course, we have two, no, DNA and cytogenetic analysis, and cell surface antigen studies, immunophenotyping provide strong prognostic information. Nowadays, many are on remission because of the advances in diagnosis. Targeted therapy could be done. The progenitor cell antigen, CD34, and the P glycoprotein, if expressed, predict a poor outcome. Why is there a poor outcome? Because more younger cells are there. CD34 is a marker for immaturity of cells. All right, so there is a chromosomal translocation, as could be gleaned from cytogenetic studies. Okay, it's a very complex karyotype. There is always problem in the chromosomes. There is maturation block. By the name itself, no differentiation. All the cells are young. Accumulation of acquired genetic alterations are also very evident. All right. Beyond morphology of cells, because we cannot depend on morphology, as there are two major groups of AML. The one with disrupted FLT gene and the one with core binding factor complex. FLT gene encodes a type 3 receptor tyrosine kinase. Upon activation, FL3 exerts a positive effects on a multitude of downstream pathways. FLT may be involved in leukemogenesis by a number of different mechanisms. FLT is known to be mutated in 30% of patients with AML. So you see, going now to molecular diagnosis, and of course, supported by this hour-rad cytogenetic and then cytochemistry, we are in for a very exact diagnosis. As you can know, molecular technology gives us 99.9% accuracy. No? Okay. So the CBF complex is a transcription, yes, no? Okay. So when a patient has this, favorable diagnosis. These two major subgroups in AML can be studied and do interaction. How about the microRNA? If we have microRNA in our patient, cytogenetics, molecular, morphological, and in AML, no? They are naturally occurring in 19 to 25 nucleotide RNAs cleaved from 70 to 100 nucleotide precursor. All right, that hybridize to complementary mRNA targets and either lead to their degradation or inhibit their translation of the corresponding proteins. So currently, microRNA is known as a new class of gene. No, this is not a discovery. No? altered, when microRNA is altered, you suspect there is leukemia or malignancy. This is another discovery. They play an important role in malignant transformation. And important thing is this microRNA can differentiate AML from ALL. Okay. We go to the old classification, the French, American, British classification. What are the basis of this old classification? But please recall, and even though this is an old classification, they improved. They have plenty of issuances. Recently, they have issuances, no? So we have the basis, morphology of the cells in both bone marrow and the blood. But we do not depend on this, as I've said, because leukemic cells are very young. They look like medium-sized lymphocyte. Cytochemistry, when we stain the enzymes, because those cells look like the same, enzymes are different. For instance, the enzyme in granulocytes are different from the enzymes in lymphocytes or lymphoblasts. Clinical feature, this will now pertain to the patient's age, race, and even the features observed by the clinician or oncologist. We go to the recent, the more modern classification by the World Health Organization. What is the basis for this? The first three from FAB, and then we now added two tests. This is based on immunophenotyping using flow cytometry, where we identify the markers on the surface of the WBC, the young red cell, the leukemic cell. CD means cluster of differentiation. And then, of course, we have the most accurate molecular technology. We study the DNA at molecular level using the DNA, using PCR machine. Now, I know you are very familiar with PCR machine. You have plenty of PCR machine in your institution. Okay, so this is the different classification. Okay, I'll skip that, no? We go to the difference now. Okay, this is the difference between WHO, WHO. No, WHO is the one we rely now. In 2016, WHO improved on its 2008 classification. What's the difference? So, in 2016, WHO exhorted more evidence of the impact of genetic molecular markers. They emphasize that the molecular markers are really important in diagnosis and disease management. Say, for example, the first, in the 2008, they called it myelogenous leukemia. In 2016, they called it myeloid. Okay. Okay, the presence of even low numbers of bona fide or true cells, blasts, prompts concern for imminent blastic phase. So, in 2016, they recognized that when there is a low number of lymphoblasts, then there might be a coming blastic phase. What is that blastic phase? The leukemic cells will now spill over to the blood, blastic phase. To diagnose accelerated phase, in the case of chronic myelogenous leukemia, this was proposed, no? The provisional response to tyrosine kinase inhibitor criteria had been added to the definition of this phase. So, we improve as we go on, and because of this improvement, then who is the winner? The patient is the winner because the patient is getting diagnosed and managed properly. So, life expectancy prolongs, and then the life of the patient is more comfortable. Oh, we another have, in 2022, during the pandemic, who was able to come up with the 5th edition? AML, the most prevalent of all leukemia, had been divided into two main groups. AML with defining genetic abnormality, no? The chromosomes, translocation, deletion, and all that. And then another one defined by differentiation. All right. These two was able to be used, is being used by oncologists. So in the 2022, the important thing to recall and remember and retain is eliminated the 20% blast requirement. For a leukemia to be called acute, there ought to be a 20% blast requirement. All right. So they have now emphasized the defining abnormality, except with AML, with ABLA1 fusion, with SEBCA mutation. That's according to J.D. Corey. This move is for, okay, I'm now giving you the reason why we like improvements. Because by removing this 20% and above requirement to be categorized as acute and using this one on the genetic abnormality, early on, the physician can diagnose, and early on, it could manage the leukemic patient.
Sorry, Dr. Charito.
Yes,
15
I'm
minutes
done.
left.
15,
15 minutes left for presenting your material. Yes.
Yes, I will wind up. I will wind up. So this, I think this could be shared naman for you because I submitted. Okay. So we have the, we go now to diagnostic tools, complete blood count. We do that, no? Morphology, immunophenotyping using our flow cytometer. Now we have cytogenetics for the inversion, deletion, and then of course the DNA analysis, no? The most accurate. So these are examples of monoclonal antibody detected by flow cytometry, no? Examples of rare forms, eosinophilic leukemia, a rarest form, basophilic leukemia. All right, we go to the ALL, the next group. The most common cancer in children, bimodal age distribution. 3 and 5 is the first peak, and then for older adults, 65. Okay. This ALL, altered regulation, and no apoptosis. All right. Let us emphasize that WHO has also looked into this. The prognosis is 35 in the past 35 years, improvement of survival rate for patients. We call ALL the leukemia of childhood. Okay. We only have L1, L2, L3 in here according to FAB. Okay, this is comparison of the slides and the morphology. What are the symptoms again? Like your AML, fatigue, fever, infection. But the striking difference is ALL could, when you have this, it could traverse the blood-brain barrier. So the patient might have convulsions. So we have the lymphoblasts here, no? Young cells, and mature, young. Okay, bigger, younger. All right. So what are the special identification techniques? As we know very well, we have to know and identify so that management could be done. TDT, found in young cells. And leukemic cells are young. We have the CALIA, or common ALL antigen, found in 70%. Okay. All right. What is the treatment regimen? Differs in ALL, even though it is also Philadelphia positive. Genetically, we look up to the problem in the chromosomes. We have ABL kinase inhibitor treatment, no, therapy. Okay. We have mixed lineage leukemia, a very important drug-resistant form. How do we diagnose? By monoclonal antibodies. As I said, when we say monoclonal antibodies, we use flow cytometry to look at the CDs. All right. The most useful antibodies are those. Yeah, these are the ones. Okay. Right. All right, life-threatening emergency infection, the cause of most death and bleeding, infiltration of organs like ALL, the brain could be infiltrated, metabolic abnormality, hyperleukocytosis. How do we treat ALL? Cytotoxic therapy, radiotherapy, and general supportive. And the in now is stem cell transplantation. Stem cell is the in thing now. How do we get peripheral blood, bone marrow, and umbilical cord? Okay. What is the goal of the future trends? To vaccinate. It's being studied now only for clinical trials now. Peptide vaccines derived from proteins called proteinase 3 and Wilms tumor can elicit highly active immunity. Lymphomas, they could either be Hodgkin's, non-Hodgkin. This is the first discovery, with genetic abnormality, the Philadelphia chromosome here, translocation. We have another. We have cytochemistry in here, summarized. We have other tests. We have the different, I have tackled this a while ago also. Clearly, hematologic malignancies are health concerns. The more the world is developed, I'm now saying my closing statement. Clearly, hematologic malignancies are health concerns. The more the world is developed, the more malignancies are recognized. There is a need then for health agencies, organizations to have concerted effort to mitigate this fast-growing health concern, which is a burden to all nations. If more money is used for therapy, then same amount should be earmarked for researches to be able to come up with more efficient and effective protocols. With that, I thank you. Thank you. With that, I thank you.
Okay, thank you, Dr. Charito, for the insightful presentation today. For the second speaker here. So now we move to the next session, the Q&A session. There is some question in the chat box. I will read it one by one.
Yes, please. Yes, please.
Okay, thank you. The first is from a student from midwifery student, Asmita. Her question is leukemia a hereditary disease, or will it be due to a lack of healthy living during one's life?
Okay, thank you for the question. Leukemia is an acquired condition. Acquired condition. And I think a healthy lifestyle and then environmental areas where toxins are limited, we can prevent leukemia. We can detect leukemia through looking at our DNA, but clearly it is not hereditary. Thank you.
Okay, thank you, Dr. Charito. Now we move to the second question. Hello, my name is Fani Apsari, also from midwifery department. Her question is based on the etiology factor slide. What role does immunosuppression, for example, for HIV treatment, play in increasing risk during pregnancy, particularly those related to hematological condition? Thank you.
Okay. As we know very well, HIV patients are being given antiretroviral drugs. These antiretroviral drugs treating HIV patients may cause immunosuppression on some clone of leukocytes. If that were so, they are immunosuppressed, and then they could now express in some other ways, leading to mutagenesis. And when there is mutagenesis, that is the start of cancergenesis. So the adverse effect of these antiretroviral drugs could have an effect on the clone of cells, which could be susceptible for mutagenesis that could lead to cancer development or carcinogenesis. Thank you.
Okay, thank you, Dr. Charito. So before I read the next question, if the participant want to communicate or asking directly with Dr. Charito, please. So by
Yes, of
writing,
course.
yeah.
Of course. I'm
Good
very
morning.
willing to answer queries. And I think I have my email there in my CV. No, I have my email. I'm very willing to really answer and entertain
Okay, thank you so
questions.
much, Dr. Charito. Okay, so the participant who want to ask directly, you also can use the icon raise hand, or
Good
so we
morning.
know if yes,
Good morning.
yes, please.
Morning.
Okay, please,
Good
ma'am.
morning, Prof. Charito.
Yes, yes.
I'm
Good
Reni.
morning,
Nice to meet you in this
Rennie.
conference.
I see you. Nice to see you,
I just
Rennie.
met you in Central Escolar
Yes,
University 2
thank
months
you.
ago.
Yes.
Okay. I have 2 questions for this session. In your slide, Prof, you describe about the environment toxin. It is the etiology factor that can contribute the hematology neoplasm.
Malignancy.
So, what can the microbiology again contribute to hematological malignancy?
You mean environmental?
Yes, for the etiology factor, you describe that the environmental toxins such as radiation exposure
Yes.
cause hematologic neoplasm. So, what can the microbiological again contribute to hematology malignancy? Okay.
Yes. Thank
And
you.
then for your slide, there are several way to treatment for leukemia. There are cytotoxin, drug therapy, stem cell, and which one the more effective for this therapy? Thank you for this
Thank you,
opportunity,
Rennie,
Prof.
for your
Charito.
question. Thank you, Rennie, for
Yes.
your question, Prof. Yes, as regards microbiology, no, we know very well that our cells responds to microbiological agents like viruses are not predicted. As you can recall, during the COVID-19 pandemic, we were all afraid of getting COVID because we know very well it's a virus, and viruses could splice in between the DNA sequence. And when they do splice or insert in the DNA sequence, there will be mutation. Example, when you splice it there, so they will have a faster rate of multiplication, proliferation, and that is malignancy. We cannot control anymore the multiplication or mitosis. Okay. What is the other question, Prof?
Which one the effective therapy for leukemia?
All right.
Yes.
Since during the past century, there are plenty of treatment regimen and protocols. We have alkylating agents. We suppress the protein synthesis. These are very crude way of treatment, and they are not targeted. So nowadays, first, precision medicine or targeted therapy is now very useful, so that when you have cancer or leukemia, the targeted ones to be treated and then killed or are those which are cancerous. And then the normal cells are not affected. That is beneficial to the patient's survival. In the past, both cancer and both normal cells are affected. But nowadays, with the advent of targeted therapy or precision medicine, the normal cells are not destroyed. Only the cancer cells are destroyed. But of course, the in thing now is stem cell transplantation. Stem cell transplantation. We know very well that plenty of researchers and even government agencies, the United States, had really gone into plenty of researches. So that's why many countries adopted stem cell therapy. Even in our country, it's very popular. And I'm sure much more popular in Indonesia,
Yes.
a very wealthy country, no? Yes, you have plenty of stem cell no,
Okay. Thank you,
procedures
Prof.
there.
Thank
Thank
you.
you.
Okay,
Salam.
thank you. Thank you, Dr. Charito. Thank you, Ibu Renionis, for your answer also.
Thank you.
So now, there are 5 participants still waiting for the answer from the chat box question. Okay, I will continue. And then from Miza Zulaika, her question is, in what ways do hematologic malignancies alter the bone marrow microenvironment? And how does this interaction contribute to disease progression and treatment resistance? Thank you.
Thank you for the question. Actually, really, our insight is that bone marrow really is the reservoir of all blood cells. Formation, differentiation happens there. It's really an environment that is wrapped by endosome. But of course, bone marrow has its own blood supply also, even though it has plenty of, it is the supplier of cells. The bone marrow has also blood vessels which supply it. So anything that is in the bloodstream or circulatory system could also be in the bone marrow. And if the patient is susceptible to a toxin or a pathogen or any abnormal content in the blood, that could also affect the bone marrow and then affect the formation of cells. There might be mutagenesis and then, of course, carcinogenesis. We are all afraid of chemicals. We are all afraid of medicines. We know very well that every medicine has a side effect or an adverse effect. But of course, the doctor will say, I will cure the patient first. Let us not mind the side effect or the adverse effect, because anything that is foreign to us could have, when we say foreign, pathogen, chemicals, that could affect our bone marrow, because by virtue of the blood supply to the bone marrow, they could reach the bone marrow, and if they are susceptible, there might be malignant transformation of clones of cells. Thank you.
Okay, thank you, Dr. Charito. Now we move to the next question from student of Medical Laboratory Technology Department, from Adinda Salsabila. Her question is, what is the role of immunosuppression in the development of non-Hodgkin's lymphoma, especially in patients undergoing HIV treatment? Thank you.
Okay, the role of immunosuppression in patients undergoing HIV, how they go into non-Hodgkin's lymphoma. Okay, non-Hodgkin's lymphoma is the more aggressive type of lymphoma. Hodgkin's lymphoma is more tamed, because I think 87% get well. But in non-Hodgkin's lymphoma, it's really like a death sentence. Even the late Jacqueline Kennedy died of non-Hodgkin's lymphoma. So, as we have said, in HIV, no, there are plenty of antiretroviral drugs being experimented on, even in our own country. HIV patients enlist in the DOH HIV program, and they are being given free medicine. These medicines had undergone clinical trials, but of course, they are still being modified and improved, and we do not know very well what will be the effect, because as we know, there is no absolute immunity. Any chemical, any drug can have a different effect on Professor Yunus, can have a different effect on Professor Mulyati, can have a different effect on Sir Zulfikar Afar. Each one of us has its own immunological constituent. That's why it was just identified that immunosuppression can happen. And this could be a part of the interplay of chemicals. In itself, they fight each other. So there might now be an offshoot or a rising effect that could now lead to malignancy because chemicals do interact with each other. That's why I always tell my students, don't ever self-medicate. Always take medicine given or prescribed by your physician. Don't do self-medication. We never know what will be the side effect to you by that drug. You might get adverse reaction. We cannot really predict because we have our own body constituent.
Okay, thank you. Can we move to the next question, Dr. Charito?
Of course, yes, please.
Okay, thank you. And then, good morning, ma'am. My name is Siti Mutiala Ila, first year student of midwifery department. I would like to ask you a few questions regarding hematological malignancies. Referring to previously described terminology material, in particular, tumor suppressor genes encode proteins that protect cells from malignant transformation. This gene usually slow cell division or promote apoptosis. My question is, what happens if these tumor suppressor genes undergo mutation or inactivation? Next, if possible, can you explain the difference between proto-oncogenesis and oncogenesis? What causes the transformation of protogenesis into oncogenesis? Thank you.
Right. Protogenes, when they become activated, when they become activated, they now convert, they mutate to become oncogenes. And when there are plenty of oncogenes, then these oncogenes will trigger. For example, a red blood cell has to produce only 16 mature red cells out of 1 pronormoblast. When there is this proto-oncogene activated by factors, they now become oncogene. They will now tell the pronormoblast, produce more, not only 16 cells. Then, in normal condition, when there is overflowing of mitotic division, there will be apoptosis. But with cancer, the apoptotic gene is turned off. So uncontrolled proliferation happens. What I'm saying is, really, malignancies is a very complex field to study. We just know that there are plenty of effects, etiologic agents, even viruses, bacteria could have an effect on one person, but might not have the same effect on another person. So the conversion of proto-oncogenes to oncogenes is triggered maybe by chemical, by bacteria, by viruses. So they mutate. The DNA is the one being affected. They go to the core of the chromosome, the DNA. And then they enter. So they say, they command. They are now the commander of the cell, of the nucleus, of the chromosome. Do more, not just 16. Do not apoptosis. Because apoptosis happens when there is no need for the cell. Even if there is no need, they turned off the apoptotic gene. That's really the concern, no? That a change from the proto-oncogene to oncogene. They are not normal cell anymore. They divide and divide and divide. That's why tumors abound in the bone marrow and then spill over to the blood. Uncontrolled, abnormal, triggered by many factors. That's why there was this instance in our country, Bataan, a province in northern Philippines, is known for its being the refugee camp after the Vietnam War. There is a military installation there, and many of my friends who are nurses had breast cancer. So the theory is maybe environmental, because there is this factory of ammunition, environmental. that was able to affect the normal cells. So this, even the bombing of Japan, di ba? Nagasaki, there are plenty of leukemic patients until now because of the effect of the bomb, atomic bomb in Nagasaki and Hiroshima. So until now, how many generations have passed? Many leukemia are being identified in those areas. Yes. Maybe if they can write me and I will answer. Give them my email. I'm very willing to really answer in detail.
Okay, thank you, Dr. Charito. Two question left. Two participant question left. I mean, good morning. My name is Laodeyaldi Hamusu, Department of Medical Laboratory Technology. His question is, what is the right treatment to treat leukemia in babies? Because as we know, babies are more susceptible to the toxic effect of drugs. Thank you.
Thank you. Many leukemias I've encountered, even leukemias of the babies of my friends, they are acute lymphocytic leukemia. Acute lymphocytic leukemia. They are on remission now. I have two friends who have kids now. They are on remission now. The protocol of treatment depends on the pediatrician, oncologist. But more often, these two friends of mine had undergone chemotherapy, their kids, and then later on, they plan to go into stem cell transplantation, stem cell. But as of now, the targeted therapy they are into, chemotherapy, targeted, precision, doing well. I met the baby 4 years old. She is now 9 years old. She is doing well. She is on remission. As I said, remission is when you do not see any signs and symptoms of the disease. So, chemotherapy, targeted therapy. If all else fail, go to stem cell transplantation. Thank you.
Thank you, Dr. Charito. The last question, last but not least. Yeah, from Chiptani. She's also the student from midwifery department. Her question is, if someone is diagnosed with leukemia and HIV simultaneously, how are the treatment approach prioritized and integrated? What are the special considerations in determining the sequence and combination of therapies? Thank you.
So you are talking about a patient who has been diagnosed with leukemia, but then he has HIV. HIV, right? Did I get the question correctly? Okay. So I think it's really a very hard, it's a very challenging clinical pattern, no? So imagine you have HIV, no? You have very poor immune system because in HIV, there is a reversal of the T4-T8 ratio. The T helper cell and the T suppressor cell are reversed. Not because there was increase of the suppressor, but there was decrease of the helper cell. And so, if you have HIV, you have very low gamma globulin. You have very low antibodies. You have very low immunity. If you have HIV, no antibodies, no immunoglobulin, no protection. That's why people with HIV are really very fragile. You are not to approach them, do reverse isolation because you might infect them. Poor immunity, no antibody. Prone to opportunistic infection, TB, pneumonia, Kaposi sarcoma, cryptococcal, they are very prone. Very hard to have this HIV. So I think when you have HIV, poor immune system, some of your T cells are really very low. And then you have leukemia. My goodness, your doctor will have a difficulty. And what a wonderful question. your doctor will have difficulty. The doctor is trying to prevent more T4 dying. The doctor is trying to improve the immune system to get protection. But here comes the bone marrow who has leukemia. There are plenty of cells, but these leukemic cells are useless. Why? They did not undergo the correct maturation stages. They are useless. They are there, but they are useless. They are just crowding. They are just crowding the cells that are being salvaged by HIV doctors. They are just crowding. And to my opinion, it has a very poor prognosis. It's a very, very difficult path to navigate. HIV and leukemia. My goodness, it's a very hard, really, very hard to navigate. Opposing treatment. So maybe in the future, they would have a medicine for that. We are concerned because in Asia, we have plenty of HIV patients, right? Okay, Asia. Other countries. Thank you.
Okay, thank you, Dr. Charita. Okay, so now I think there's no question anymore in the chat box, or there is no one raising also. So we move to the next session. I will read the summary of this presentation of Dr. Sherba. Before that, a big appreciation, especially for me, because what you explain is not only for medical laboratory technology, but it is awareness for other health profession also. I mean that we have to increase the quality of our life also for preventing this condition, I mean malignancies. So the summary of this presentation is the first. Hematologic malignancies are cancer that originate from abnormal cell growth in the blood-forming system, such as the bone marrow and blood. These cancers are not inherited and were first recognized by Fitko in the 19th century, who identified leukemia. The causes of this cancer include environmental factors like radiation or exposure to harmful chemicals, the use of medication that damage DNA, and viral infection like HTLV-1 and EBF. There are also inherited genetic factors that can increase the risk. On a molecular level, blood cancer occurs due to the mutation in genes that control cell growth, DNA repair, and the cell cycle, leading to uncontrolled cell proliferation. Hematologic malignancies are divided into three main types: leukemia or blood cancer, lymphoma or cancer of the lymph nodes, and myeloma or plasma cell cancer. Leukemia is further classified based on how quickly the disease progresses, acute or chronic, and the type of cells involved, such as white blood cells or lymphocytes. Leukemia can be distinguished from other conditions like leukemia, leukemioid reaction by laboratory tests that show the presence of immature cell in the blood. The more I take the quotes in your last slide, that the more the work is developed, the more malignancies are recognized. There is a need then for health agencies, organizations to have concern, effort to mitigate this fast-growing health concern, which is a burden to nation. It means that it is not one profession, health profession responsibility, but all the profession need to focus on this, and to also your I take your quote also, do not do self-medication, but take the medication as prescribed. So prevention is better than cure. So controlling the modifiable factor is very crucial, like our lifestyle or to increase our quality life. Okay, thank you, Dr. Charito, for the nice and insightful
Thank you, Dr.
presentation.
Charito. Salamat po.
Very impressive.
Thank you.
Yeah,
Very completely, Prof.
yeah. So before we close the session of Dr. Charito, we will present the certificate of appreciation to
Certificate.
you.
Thank you.
So please, the operator, to present the certificate. Sorry, before that, may please your screen still your slides.
Yes.
Yes, still.
Stop share.
Yeah. Yes.
Stop share.
Yes, stop
Thank
share.
you.
Okay, thank you.
Thank you.
Okay.
Thank you.
Okay. This is the certificate of appreciation for Dr. Charito M. Bermido, BSMT, RMT, MA, MS, MT, PhD as a speaker at the first International Conference Center of Excellence, Preventing Stunting and Heart Disease for a Quality Future Generation, held Poltekkes of Kendari, Indonesia on November 29 to 30, 2024. Thank you so much, Dr. Charito. We hope that you are in a healthy condition, and we hope that we can also see you directly, not Ibu Reni Yunus only. Yes.
Yes. Thank you very
in your
much for
country or
inviting me.
Indonesia. Okay.
Yes.
Thank you,
I
Dr.
really
Charito.
appreciate you all. Thank you very much.
Thank you,
Thank
right.
Thank
Okay.
you, Prof.
Big
Salamat
applause
po.
for Dr. Charito.
Okay.
Yeah, thank you very much. See you again, Dr. Charito.
See you again, Prof.
Yeah, see you. Bye.
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 Bye, bye, Prof.
Yeah.
Bye.
So ladies and gentlemen, this is the last session for the first presentation from our speaker in the day one. We will be continue again in 1 p.m. In local time. Jadi kita akan melanjutkan kembali kegiatan kita, presentasi dari narasumber selanjutnya di pukul 1 waktu Indonesia Tengah, sehingga kami memohon kehadiran dari partisipan sekalian untuk tetap stay dan bisa mengikuti kegiatan kami di hari ini sampai selesai, dan insya Allah besok juga hingga kegiatan selesai. So for a while, we'll close our session. We will continue in 1 p.m. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh, and good morning.
Waalaikumsalam warahmatullahi wabarakatuh.
Ada Bu Muli. Link absensi sudah ada Bu Muli.
Untuk link absensi nanti setelah sesi sebelum materi terakhir akan diberikan. Jadi mohon tetap di dalam link Zoom.
Oh, berlanjut lagi sebentar di Ibu Tin ini.
Iya, nanti masih ada 2 pemateri. Sebelum pemateri yang keempat, baru kami share untuk link absensinya.
Iya, baik Bu Tini, terima kasih.